Okay, so good day, everyone. So here's another topic that we have here in serology. And for today, we will be discussing about the serological and molecular detection of bacterial infections. So for this particular topic, we will be discussing the host microbe relationship, the bacterial structure and virulence factors, immune defenses against bacteria in a skip, laboratory detection of bacterial infections, and clinical manifestations and laboratory detections of selected bacterial infections such as the group A, Streptococci, Helicobacter pylori, Mycoplasma pneumoniae, and rickettsia infections. Okay, so let us review the host-microbe relationship. Okay, so these are the different examples of host-microbe relationship. So one of them is the so-called host microbe. They live together for a long term. So that kind of relationship is known as symbiotic. So an example of such kind of relationship would be the indigenous microbiota in our body. So for example, females would have Lactobacillus acidophilus as part of the indigenous microbiota, or normal strain of Escherichia coli may reside in our gastrointestinal tract. But when we say commensalistic, microbes will live inside our body, but we will not benefit from it, neither they will also harm us. Okay. But when we say mutualistic, both the host and microbes would benefit from such kind of relationship. Now, the fourth relationship is the one that we do not want to experience, because here, when you say parasitic relationship, microbes can cause harm to the host himself. Okay, so these are the different host microbe relationship. Okay, so let's define what we mean by infectivity, pathogenicity, and virulence. Okay, so when you say infectivity, infectivity is the ability of the microbes or of the organisms to establish an infection. Hence, they are pathogenic. But when you say pathogenicity, it is the ability of an organism to cause a disease. And when you say virulence, it is the extent of pathology caused by an organism when it infects a host. And of course, it is also confounded by the presence of virulence factors, such as the presence of capsule, the presence of endospores. Okay, so these are some of the examples of the virulence factors. Okay, so again, as a review of your bacteriology, these are some of the structural components of the bacteria. So I did mention a while ago, capsule, it can prevent phagocytosis. Pili is important for the conjugation. Flagella would be important for motility. And then plasmid is an extra chromosomal circular DNA. It may contain genes that could encode, for example, for antibiotic resistance. So these are some of these structural components of the bacteria. Now, noteworthy to mention that some of these components could also be a source of bacterial antigen needed for serological testing. So, for example, the cell wall during the without test could be the source of somatic or the O antigen, while the flagella could be the source of the H antigen. So some of these components may also serve as bacterial antigen. Okay. So a while ago, I was talking about the virulence factors. So these are some of the most common types of virulence factor. So let's discuss them one by one. So we have the endotoxin. Endotoxin is the lipid A portion of the lipopolysaccharide, and it is primarily found in gram-negative cell wall. So not all bacteria would have endotoxin. So it is primarily found in gram-negative bacteria. So Neisseria meningitidis, I hope you could still recall that, is would have LPS as its major virulence factor. So it is a powerful stimulator of cytokine release. Okay. So the other one is pili. Pili is important for adherence or the anchorage of the bacteria to the host cells. And it may also help to resist phagocytosis. Okay. So if it can transfer genetic materials from one cell to another, it is specifically known as the sex pili. But for bacteria such as Neisseria gonorrhoeae, it will use its pili or the febrile to attach to the epithelial cells. Number three is flagella. Flagella would be important for adherence to cells and most importantly for motility. And then we also have capsule. Capsule can block phagocytosis and antibody attachment and the attachment of the complement components. And the fifth one is exotoxin, a potent toxin proteins released from living bacteria, and it could be categorized as neurotoxin if it affects our nerve cells. Cytotoxins is a general term that can affect any kind of cells, and enterotoxins if it affects the cells of our gastrointestinal tract. Okay? So exotoxins can be found in both gram-positive and gram-negative bacteria. So as part of our defense, we could have the innate defense or the natural immunity or our non-specific immunity. So this include the presence of the intact skin and of course the mucosal surfaces would serve as a barrier to prevent the entry of these microorganisms. And naturally speaking, we also have antimicrobial defense peptides, lysozymes present in our saliva or in our tears, and that would also include other defense peptides in our body, such as defensins and ribonucleases. And then, of course, our complement proteins, cytokines, and acute phase reactants would be produced in cases of inflammatory reactions. And recognitions by PAMs and PRRs, such as the toll-like receptors, which are important for phagocytosis. Now, aside from our natural immunity, we also have antibody adaptive defenses, otherwise known as our specific immunity, which can either be a humoral immunity, which would involve antibody production, and cell-mediated immunity. So, by the way, when you say antibody production, this will involve binding of complement component, opsonization, and even neutralization of bacterial toxins. But when we say cell-mediated immunity, this would involve the CD4 or the T helper cells, which produces cytokines that can induce inflammation, and then the cytotoxic uh, T lymphocytes or your CD8 can attack host cells that contains intracellular bacteria. So I hope you're still familiar with the perforin and the granzyme system when our cytotoxic T cells attack bacteria with intracellular infection. Okay, so um, this is the bacterial evasion mechanism. So bacteria can actually prevent phagocytosis, can actually prevent phagocytosis they have if they have capsule. If they are motile, they can actually move from one place to another. So the bacterial evasion mechanisms are greatly enhanced because of the presence of the various virulence factors. Okay, so for this particular, of course, session, we will be discussing what are the different ways of detecting bacterial infection. So conventionally, we can culture the bacteria, okay, on broth or in solid media. So that's the conventional way of doing it. It's a major means of diagnosis, but it may take time because it will take, for example, 24 hours for an ordinary bacteria to grow, but for tuberculosis, it would even take about several weeks, no? And sometimes culture may not be possible, particularly for extremely pathogenic bacteria such as rickettsia or chlamydia, would even require live tissue culture or live cell culture. Okay. So microscopic examination is another possibility of diagnosis, but it is not really that confirmatory specific. Here, we can determine whether the infection is caused by gram-positive or gram-negative bacteria, or we can determine also the special structure of the bacteria by means of special stains, such as the stain for metachromatic granules, the stain for spores, or the stain for capsule A. So we can also determine bacterial antigens. So rapid testing by means of ELISA or by means of lateral flow assays or lateral assays. So we can determine the presence of bacterial antigens. And of course, nowadays, molecular techniques will give us more specific way of determining the DNA or the RNA structure by determining the 16S RNA, 16S RNA of the bacteria. We can even speciate the bacteria and even discover new species for that matter. So through PCR or polymerase chain reaction, and in which results could be obtained in few hours. However, for this particular session, we will be focusing mostly on the detection of bacterial antigens. Okay. So, however, when we detect bacterial infections, particularly clinically speaking, most of the time we do serological assay. So, when you say serological assay, we detect antibodies against bacterial antigens. So, since we detect antibodies, our specimen for diagnosis is a serum. So serum is our specimen for diagnosis. So here, what are the advantages or the utilization of serology? We can detect and confirm infection from which other laboratory methods are not available. Okay. And then we can diagnose infections from which clinical symptoms are non-specific because there are non-specific symptoms such as diarrhea. So diarrhea could be attributed to any other kind of etiologic agent. Or we can determine current infection if the person is positive by IgM. Okay, so IgM is actually a primary response. Or if there has been a high IgG titer or four-fold rise in the antibody titer between acute and convalescent samples, it means that the person is about to recover or recovering already because of the high IgG titer. Why? IgG titer, IgG is secondary response. Okay. So this will determine past exposure to an organism. So for example, if a person is positive with IgM, negative with IgM, but positive with IgG, it means that the person has been infected in the past already. So do not forget, in antibody testing, IgM is an indicator of acute infection. IgG is an indicator of convalescent phase. Here we can also determine assess reactivation or re-exposure. The disadvantage, however, of antibody testing for bacterial antigen is that there is a delay between the start of infection and production of antibodies, particularly if you will be measuring the serum of the patient at the early stage of the infection. So that won't even be possible. So another disadvantage is that for some immunosuppressed patients, immunocompromised patients, there would be low antibody production. So there would be a very low antibody production. Okay, so let us discuss some of the most common bacterial infections wherein we can possibly employ serological testing. And one of them is group A streptococci, and our representative organism for group A streptococci is Streptococcus pyogenes. It is a gram-positive cocci arranged in pairs or in chains, and person-to-person transmission is even possible. So, group A streptococci is the most common etiologic agent of strep throat, sore throat, a bacterial infection of sore throat, pyoderma or impetigo, scarlet fever, toxic shock syndrome, necrotizing fasciitis, and it is usually treated with antibiotics. So if you do remember, necrotizing fasciitis, this is a condition wherein the fascia, that's actually a tissue in between the skin and the muscles, are already infected. And it is appear as if someone is actually eating your skin. So that's the reason why they say Streptococcus pyogenes is an example of a flesh-eating bacteria. So here is an example of strep throat. So characterized by enanthem. These are the rashes in the mucous membrane. But if the rashes are found in the skin, we call it exanthem. Okay, so here is an example of impetigo, okay, caused by Streptococcus pyogenes. However, what scares me the most is not the acute infection itself, but the consequences of having a group A streptococcal infections because of the possibility of the sequelae. So when we say sequelae, we are referring to the consequences of having streptococcal infection. One of them is called the acute rheumatic fever, and it develops 1 to 3 weeks after having pharyngitis or tonsillitis or having sore throat in 2 to 3% of infected individuals. So here, symptoms would include fever, joint pain, and what makes it worse is the inflammation of the heart, which could lead to heart attack and it could be fatal. So most likely, it is caused by the immune response to streptococcal antigens that cross-react with human heart tissue. So your immune system thought that it's actually destroying streptococcal antigen, but not knowing it is already destroying the human heart tissue. Hence, it's an inflammation of the heart. Okay. Another consequences of having streptococcal infection is post-streptococcal glomerulonephritis, which may follow strep infection of the skin or of the pharynx. So it will damage the glomeruli of your kidneys, producing hematuria, which is actually the presence of blood in the urine. Proteinuria is the presence of protein in the urine, and it is also characterized by edema, hypertension, malaise of body weakness, backache, abdominal discomfort, and even impairment in renal function. So, post-streptococcal glomerulonephritis is characterized by the deposition of immune complex containing streptococcal antigen in the glomeruli. So, if this is the basement membrane, so antigen together with complement component will be deposited here. So if you do recall our discussion on hypersensitivity reaction, this particular scenario represents the type 3 hypersensitivity reaction. So the position of immune complex will attract neutrophils, and neutrophils will attack the immune complex, thereby damaging the kidneys itself. Okay? So these are the consequences of having group A streptococcal infections. So therefore, if you are a clinician and you are suspecting that the patient is having streptococcus infection, then it's very important that the physician should give appropriate antibiotics through proper diagnosis. So how could we properly diagnose group A streptococcal infection? Okay, so one of them, of course, as what I told you, we can do the conventional way, which is to culture the streptococcus on sheep's blood agar. And since they are beta hemolytic, so you'd be able to see translucent colonies surrounded by colorless zone. So if you recall, when you say beta hemolysis, we are referring to complete type of hemolysis. Now, to determine also whether it's a group A streptococcal infection, we can do the lateral flow assay. So this is a rapid assay to detect group A streptococcal antigen. So the lateral flow assay is characterized by double band, by the double band. So from here we can actually do the lateral flow assay. So it's this one is commercially available for this illustration. The brand is Binax now for strep A. So again, this is the sheep's blood agar wherein you can find colorless colonies since um, group A streptococcus is beta hemolysis can produce beta hemolysis. So anti-streptolysin O is another test, okay, for the determination whether the patient is vulnerable for group A streptococcal sequelae. So what's the principle? When you are infected with streptococcus, okay, the organisms would have two hemolysin, two types of hemolysin, no? So streptolysin S and the other one is streptolysin O. Streptolysin S is non-antigenic. Streptolysin O is antigenic. And it is actually responsible for subsurface hemolysis. Streptolysin S is responsible for surface hemolysis because it is oxygen stable, unlike streptolysin O, which is oxygen labile. And since it is antigenic, therefore, we can produce antibodies against streptolysin O. And the name of antibodies against streptolysin O is known as the ASO or the anti-streptolysin O. So the anti-streptolysin O can be determined using the nephelometric methods. Nephelometric methods meaning to say we measure the black light. Okay, so it's a turbidimet. It's actually an example of um, light scattering assay. Okay, so we measure the scattered light. Sorry, but turbidimetry measures the black light. Nephelometry measures the scattered light produced by immune complex containing the streptolysin antigen. So titer elevated in 85% of the patients with acute rheumatic fever. So if your titer is elevated, and majority of the patients with elevated titer are found to be positive for acute rheumatic fever. So it does not increase in patient with skin infection. However, nephelometric method is quite an expensive method. So that's the reason why in the laboratory, the most common method is the ASO latex agglutination assay. So here we add patient serum plus latex particle and we measure the antibody titer. Okay, so normal antibody titer should be less than 200 international unit per ml. So if your antibody titer is greater than 200 international unit per ml, it's actually a red flag for the clinicians. So you could be at risk of getting acute rheumatic fever and acute glomerulonephritis. So aside from ASO, we do also have the anti-DNase B. It is produced by both rheumatic fever and impetigo patient, and it is tested by enzyme immunoassay and nephelometric methods. Streptozyme test can also detect antibodies to 5 streptococcal products. So it wouldn't only test for ASO, it would also even test for anti-hyaluronidase. By the way, hyaluronidase is a spreading factor. Okay? Hyaluronidase is an enzyme that can lyse hyaluronic acid, a component of the ground substance found in the connective tissue. Hence, it is known as the spreading factor. Anti-streptokinase is an antibody against streptokinase enzyme. So, streptokinase enzyme is the enzyme that can lyse blood clot. So, that's the basic function of anti-streptokinase. And then anti-nicotinamide adenine dinucleotide, NAD, is an important coenzyme as well. And anti-DNase B, DNase B is an antibody. DNase is an enzyme that can, of course, liquefy or that can destroy the DNA component. Okay, so streptozyme test will test not just ASO, but these all 5 antibodies, which would be more meaningful for the clinicians to interpret possible sequelae with group A streptococcal infections. Okay, so let's talk about Helicobacter pylori. So Helicobacter pylori is a gram-negative microaerophilic spiral bacterium. Microaerophilic means that it would only require small amount of oxygen in order for them to grow. So the transmission is likely by fecal oral route and it's the major cause of gastric and duodenal ulcer. So the organisms can survive in acidic environment of stomach because of the production of the urease. So the urease is an enzyme that can neutralize hydrochloric acid, which provides buffering zone around the bacteria. Hence, normally, bacteria cannot survive in the because of the corrosiveness of our gastric juice. But because of Helicobacter pylori's ability to produce urease, it can neutralize the corrosiveness of hydrochloric acid. Hence, they are able to survive in the um, gastric environment. So, Helicobacter pylori is the etiologic agent of ulcer, stomach ulcer. So, it is usually if a person has Helicobacter pylori, it is treated with antibiotics and anti-ulcer medication. If untreated, it can lead to gastric carcinoma and mucosa-associated lymphoid tumor. So under the electron micrograph, this is how Helicobacter pylori is depicted. So how do we detect Helicobacter pylori infection? First is we can detect it using the detect urease in stomach biopsy through flow test, which is commercially available. So we just add, okay, the biopsy material here, and if it turns dark pink, then it's positive for Helicobacter pylori. Negative, yellow means it's negative for Helicobacter pylori. We can also detect urea breath test. So how do we do it? We give radioactive urea to the person, and then and after a while, after quite a while, so this radioactive urea is being given, and then the person will breath, and the amount of the urea will be produced will be detected in a scintillation or in a gamma counter. So so if urea is broken down because of the presence of the urease in the stomach, and that uh, urease is produced by Helicobacter pylori. So it means that if it's detected in the gamma counter, then it means that you have Helicobacter pylori in your stomach. And then Helicobacter antigens, Helicobacter pylori antigens, another possibility. And a much simpler way of doing it is Helicobacter pylori antibodies, wherein ELISA is a method of choice, and all we have to do is to detect IgG in the serum, which would indicate active infection. If the titer decrease after, for example, antibiotic treatment, it indicates successful therapy. Okay, then let's talk about Mycoplasma pneumoniae. Pneumoniae. Mycoplasma pneumoniae is an example of PPLO. I hope you can still recall it back then in your bacteriology. PPLO is a pleuropneumonia-like organisms. They are highly pleomorphic since they do not have cell wall. So it's a leading cause of respiratory infection characterized by fever, headache, malaise, and cough. And it is also the etiologic agent of the walking pneumonia phase because some patients could be asymptomatic, characterized also by Raynaud's syndrome, as you can see here. Okay, so there is a constriction in the small blood vessel, and your hands would turn white due to the lack of blood flow, blue due to the lack of oxygen, and red when blood flow returns. So that's the Raynaud phenomenon. And then it causes Steven Johnson syndrome in minority of cases. So we can get infected by Mycoplasma pneumoniae through respiratory droplets. So how do we detect laboratory diagnosis of Mycoplasma pneumoniae? Okay, so we can actually culture it. It produces the mulberry colonies that appears like fried egg on specialized media. It is considered as the gold standard, but it is rarely performed in clinical laboratories because the organism is difficult to grow. Therefore, a simpler way of determining it is through antibody testing. So this one is the most useful diagnostic assay. So here, IgM means that it is a recent infection. IgG means a possible reinfection. Now, majority of the patients with Mycoplasma pneumoniae will produce cold agglutinins, particularly in about 50% of patients with Mycoplasma pneumoniae. However, the presence of cold agglutinins is not specific for infection with Mycoplasma pneumoniae. So, cold agglutinins means that the RBC will agglutinate when incubated at 4 degrees centigrade, but agglutination will disappear when incubated at 37 degrees centigrade. Meaning to say, 4 degrees centigrade is the optimum temperature for the agglutination of the RBC. But of course, the most specific method for the detection of Mycoplasma pneumoniae is through the film array respiratory panel. The film array respiratory panel will not only detect Mycoplasma pneumoniae, but other possible etiologic agents that can cause respiratory infection. Okay, so that is the film array respiratory panel. Okay, so let's talk about the febrile agglutination test. So the febrile agglutination test is actually a group of bacterial infection that can be positive in agglutination tests such as the Widal test and the Will-Felix test. Widal test is caused by Salmonella and Will-Felix is caused by rickettsia. Okay, so these are our example for febrile agglutination test. Okay, so Widal test is a test for typhoid fever. Will-Felix test is a test for typhus fever, which is caused by rickettsia. And then there is also a test for Brucella antigen and a test for Francisella tularensis. But for now, we will just be focusing on Vidal and Will-Felix test. So the antigens for Vidal test is the O antigen, or somatic antigen, and it is derived from the cell wall. And then the H antigen is a flagellar antigen. So obviously, it is derived from the flagella. And the A and B antigen is the antigen for Salmonella paratyphi. Both of them are somatic. Therefore, both of them were derived from the cell wall. Somatic antigen is characterized by compact agglutination. And the reason why we call it O is because of the on phenomenon. So compact agglutination. H antigen is characterized by fluffy agglutination, and it is known as the on-haunch phenomenon. Let me write it legibly. On-haunch phenomenon. Okay? So, without test can either be done using the slide method or the tube method. Okay, so the advantage of slide method is that you can actually observe agglutination under the um, microscope. Okay, and then the advantage of the tube method is that you can centrifuge the tube and further evaluate or grade the agglutination as to plus two, plus three, plus four, plus one, or even negative. Okay, but most common way of doing it is through the slide method. So here, let me get a blank screen here. Um, we can have four dilution, no? Five dilution. We can have 1:20, 1:40, 1:80, 1:160, and then 1:320. So here we add serum from the patient. So if it's a 1:20 dilution, we add 0.08 ml. So it's in ml. 1:40, we add 0.04 ml. 1:80, we add 0.02 ml. 1:160, we add 0.01 ml. 1:320, we add 0.005 ml. And then we add antigen. How many drop of antigen? We add one drop for each well. And then we grade the agglutination. We grade the agglutination in each well from +4 up to negative. So possible grades could be +4, +3, +2, +1, and then negative. Now, the significant titer is at least 1:80 showing +2. Okay? 1:80 showing +2. So it should be significant. So for example, for this patient, let me write again. So we have actually four antigens. So let's say, for example, for patient 4 in 1:20 well, it is +4, +4, +3, +2, and +1. For each antigen, it is +2, +1, negative, 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 +1 here, +1, then negative, negative, negative. And then plus for B antigen, it is +2, then +1, then negative, negative, negative. You have to look at this. You have to look. Oops. I lost it. Okay. Okay, let me try to draw again. My apologies. 1:40, and 1:80, 1:160, and then 1:320. So again, we have four antigens. Here you have +4, +4, +3, +2, and +1. Here you have +2, +1. For example, this is the test, the reaction of the patient. +1, negative, 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 negative. Then you have +2, negative, 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 negative. Okay, so you have you have to look at this box because 1 is 20 and 1 is 40. These are not significant. So here, what is the titer of O? The titer is at least showing +2 for Vidal. So the titer of O is 160 showing +2. And it is considered to be as significant. What is the titer of H? The titer of H is this. The titer of H is 20 and it is not significant. Why? It is below, falls here. So anything that falls here is not significant. What's the titer of A? A has no titer. Why? Because there's no +2 for A. Again, we only consider it if we consider it as a titer if it's at least +2. And what's the titer of B? The titer of B is 20 and it is not significant. Why? Because it only falls here. Okay, so the only one that has a significant titer is O. For this particular example, the only one that has a significant titer is O. Okay, so that's how we interpret. That's how we uh, that's how we analyze the without test. Okay, so if O is significant, what does it mean? If O is significant, it means that there is an active or current infection. So if it's O, that is significant. If H is significant, it means that there is a past infection, there has been recent immunization, convalescent, or exposure. Okay? And if A or B, if significant, this represent paratyphoid fever. If O plus A or B, it represents mixed infection. So by the way, this is how the anti-sera look like for the without test. Okay, however, without test is not anymore being done because what is more popular in the laboratory is the typhi dot test. So it is consisting of a dot ELISA kit that can detect either IgM and IgG antibodies against the outer membrane protein of Salmonella typhi. So OMP protein. Okay? So the typhi dot becomes positive within 2 to 3 days of infection and separately identify IgM and IgG antibodies. So again, is no longer Vidal as is known is not as popular as typhi dot nowadays. So the test is based on the presence of specific IgM and IgG antibodies to a specific 50 kb OPM antigen. So again, this is the source of antigen. And what are we detecting? We are detecting anti-OMP, which could either be IgG or IgM. So if it's positive with IgM, it means that there is a recent infection. If it's positive with IgG, it means that there has been a remote infection, remote or past infection. So, but however, it is also time consuming, sabi rito. Okay, but there is another rapid test already for typhi dot that is not time consuming anymore. So, however, the most important limitation of this test is that the kit is not quantitative and the result is only positive or negative. Unlike with DAL, it will tell us the titer of specific antibodies. So that's the advantage naman of the without test. However, both tests lack sensitivity and specificity. So the without test is losing its value as it is labor intensive. Imagine you have to do several wells. But rapid test is already available for typhoid test. So let's compare, no? When it comes to sensitivity, if it will be comparing blood culture with the typhoid and diazo test, okay, during the first week of illness, the most sensitive is the typhoid IgM test during the first week. It's not the IgG, IgM. But the one that is most specific is blood culture and also without 100% specificity. And it also has a very high, uh, not without, not typhoid, also has a very high positive predictive value as compared to the blood culture. And the negative predictive value is also very high. So blood culture is not as sensitive during the first week of infection, and it's actually more time consuming. Okay? So Will Felix test. Will Felix test is the test for rickettsial antibody. Okay? Rick, uh, for rickettsial infection, which utilizes antibodies against proteus antigens. So let me correct myself there. So the proteus antigens that we are using here are the OX2, OX19, and the OXK, which came from the Kingsbury strain. So, unlike in Vidal test, the significant titer here is at least 1 is to 160, even plus 1 is already considered as positive or significant. Unlike in Vidal, it has to be at least 80 plus 2. But for Will Felix, 160 plus 1 is enough. Okay. So rickettsial infection. So let's talk about rickettsia. Let's recall. Rickettsia is an obligate intracellular gram-negative bacteria wherein culturing these organisms could be very dangerous. There are several groups of rickettsial infections. It could be the spotted fever group. Our representative organism for this one is the spotted Rocky Mountain spotted fever. And we also have the typhus group or the epidemic typhus. So the organisms are transmitted by arthropods such as ticks, mites, lice, or fleas through biting and after feeding on an infected animals. So these are the common rickettsial infections. So Rocky Mountain spotted fever is caused by rickettsia. It is tick-borne. Ehrlichiosis is caused by Ehrlichia canis. It is not a rickettsial infection. Rickettsial pox is caused by Rickettsia acari. Scrub typhus is caused by Rickettsia chuchugamushi. Both of them are mite-borne. Epidemic typhus is caused by Rickettsia prowazekii. Trench fever is caused by Rocalumeri quintana. Both of these are louse-borne. Murine typhus is caused by Rickettsia typhi. Q fever is caused by Coxiella burnetii, so it's not a rickettsial infection. So there's no specific vector for this. Okay, so Rocky Mountain spotted fever is caused by Rickettsia rickettsii, and it is transmitted by 3 species of ticks. So symptoms would include headache, nausea, vomiting, diarrhea, skin rash, and even death. So clinical presentation is this. So there's a rash. And serology. Nowadays, Will Felix test is losing its popularity. So a more specific test is the indirect fluorescent assay. Why? Because Will Felix test has poor sensitivity and poor specificity. So that's the reason why indirect fluorescent assay is now considered to be as a gold standard, and it is useful in investigating outbreaks or epidemics. So Will Felix is not specific and it's not sensitive. So let's say, for example, for Rocky Mountain spotted fever, it is positive with OX2 and OX19. And it has the same result for epidemic typhus. For scrub typhus, it's only positive with OXK. For murine typhus, it has a variable result for the OX2. So again, it's not specific. And it's not sensitive because it cannot detect rickettsial pox. It cannot detect French fever. It cannot detect Q fever. It cannot detect ehrlichiosis. So that's the reason why it is not specific and it's not sensitive. So that's the reason why nowadays, in the laboratory, it is much better to use indirect fluorescent assay for the detection of rickettsial infections. So that's the end of our topic for the serology and molecular detection of bacterial infection. So thank you very much for listening. We will have a separate session for treponemal infection. Thank you very much. Bye, everyone.